minutes to let everyone connect to audio and to finish entering the webinar. Okay, we'll go ahead and get started. Welcome to the 2025 Title 24 Triennial Code Cycle Update for Part 1 and Part 2, Volume 1, brought to you by the Department of Healthcare Access and Information, otherwise known as HCAI. You may download the presentation for today's webinar in the Go To panel under the Materials section. We will be answering questions at the end of the presentation and during intervals throughout the presentation. If you have questions, please type them in the question panel. We will not be answering questions from raised hands during today's presentation, so please type all your questions in the question panel. If you experience transmission difficulties during the presentation, please log out and rejoin the webinar using the login information that was sent to you by GoTo. Next slide, please. Today's presenters are Mia Marbelli, the Supervisor of the Building Standards Unit in HCAI OSHPD, and Samantha Miller, the Senior Architect of the HCAI OSHPD Building Standards Unit. Next slide. AIA California will be submitting AIA members who attended this webinar for 1.5 learning unit credits. You do not need to self-certify. Just a reminder, you must be individually logged on to receive credit. Once again, thank you for joining us today, and I'll hand the presentation over to Mia.
Thank you, Simran. Appreciate that. Good afternoon. I'm Mia Marbelli, Supervisor of the Building Standards Unit. We're going to go through Parts 1 and Part 2, Volume 1. I'll start with Part 1, the California Administrative Code. These are the 2025 code changes that go into effect January 1. And actually, I'll point out something here in a minute about a different effective date for the admin code. There were some significant changes in Chapter 6 for the seismic evaluation procedures for hospital buildings. I'm not going to go through those, but I want to bring your attention to some webinars that our seismic compliance unit provided earlier this spring to assist design professionals and hospital owners and operators. The information for the webinars can be found on the link provided in the PowerPoint. They had about 4 webinars earlier this spring, and it helped with the process for submitting the seismic compliance projects, but then it also helped with a new law that went into effect earlier this year as well for rural and small hospitals. So just a reminder that the California Administrative Code has a different effective date than the rest of the parts of Title 24. There's a provision in law that allows administrative regulations to become effective 30 days after filing with Secretary of State. And really all that means is 30 days after the commission approved it, and then they filed it with Secretary of State. And so the effective date for the admin code was March 29th, 2025. And then we have a link here for the final express terms that are available. But by now, you should all have your published new California Administrative Code. Back in February, the Seismic Compliance Unit provided a webinar talking about Small and Rural Hospital Relief Program. The bullet points here describe what the webinar was about. The video is available online. And then they had another webinar that went further into detail about the eligibility criteria for small rural critical access district and distressed hospital loan program for Assembly Bill 869 that allows for, I don't want to use the word extension, but for a delay in the deadline of up to 3 years. But there's criteria that these hospitals must comply with and request of HCAI before getting that delay. And that information is provided in the webinar. So I'm going to cover the administrative code changes that are in Chapter 7. And these are more of the, building department type code changes, definitions, submitting plans, the process involved in your plan review. We updated a couple of definitions, just clarifying that a building does not have to be adjacent to another building to be a freestanding, and that the separation requirements apply to all adjacent buildings and not limited to hospital buildings. Just an update to the correct name of the California Building Standards Code. And then you may recall that legislation a couple years ago changed the name of OSHPD to HCAI. It became a department. And then our office became the Office of Statewide Hospital Planning and Development. And that's just an editorial change to the code. And that was done kind of throughout the code over the last couple code cycles where we catch the sections that need it. Section 7-113, this is, A is rewritten just to itemize the documents that are required for submission. Really, the intent hasn't changed. It's just cleaning it up, making it more user-friendly to read. There's a pretty good change here in the preparation of documents. We coordinated this with the Board of Professional Engineers, Land Surveyors, and Geologists. We received a petition a year or so ago requesting why can't fire protection engineers submit plans that are within their responsible charge. And so we worked with the Board of Professional Engineers and we developed this code change that now permits fire protection engineers to submit projects that are within their responsible charge. And then we also had some comments and feedback that we needed to add professional engineer within the title of engineer to help clarify it. This is little b in the same section, kind of similar changes here. A civil engineer or an architect shall be permitted to prepare construction documents, reports for anchorage and bracing. We wanted to clarify that for certain components, and then adding that a fire protection engineer is permitted to prepare documents, reports for fire protection systems. Clarifying here that rather than using the word individuals, we're specifying firms, an inspector of record, or contractor. One reason for this change is an architect or an engineer who works for a large firm or firm and prepared the set of construction drawings or documents for a project. They may be replaced if they leave the firm or go elsewhere. However, the firm is the responsible party. If the architect or engineering firm is replaced, that would trigger the requirements of 7-152. Changes to approved work. So changes that do not materially alter the work. We repealed items 1 and 2 out of the 8 items that were in this section. So those are renumbered to 1 through 6. And the reason for this is items 1 and 2 were not really non-material changes at all. They didn't apply. Item 1 is a basic clarification, and item 2 is a construction means and methods, and HCAI doesn't have authority for either one of those. We did revise a CAN to help explain this because there was some confusion. And it may be that we look at these regs a little bit more in the next code cycle. And I'm going to shift over to the next slide. I believe I'm going to turn this over to Samantha Miller, who is our senior architect, and she's going to provide just some information on the changes that are in CAN 7-153B. So I'll turn it over to Samantha.
Thank you, Mia. This CAN defines non-material and material altering changes. It describes the process for obtaining NMA concurrence in the field and includes change forms, logs, and an illustrated workflow for the overall NMA process. This CAN has gotten a lot of attention since April, as we've adjusted it to best meet the intent of the administrative code changes. As Mia said, the code changes reflected the reality that OSHPD does not have authority over basic RFIs and construction means and methods. This year's updates clarifies the use and modification of existing approved details via NMAs, and that the signatures required for NMAs can be provided by the architect in responsible charge of the change itself. Language was also updated to clarify that the examples in the document were just that, examples, and are not intended to be clerical categories. And I'm going to turn this back over to you, Mia.
Okay. All right. Next, pretty simple change here, but it really is going to help out our office quite a bit. We would often receive verified compliance reports and tests and inspection reports, but what we're indicating here is that it's necessary to file the final verified compliance reports and final test and inspection reports to the office. This is necessary. On occasion, what would happen is we would get them filed, but the reports were not final or verified and did not pass. So, okay, we are now going to shift to part 2, volume 1, which is the bulk of the code changes. I do see one question about the fire protection engineer, and I think what I'm going to do on that question is respond to that maybe after the presentation. I don't know if we mentioned this earlier. We're going to try to get through as many questions as we can. But what will happen is we're going to download these questions and then do some responses and post them online. It'll give us some time, maybe a week or 2, to get back to you on that. So in chapter 1 of the building code, and this is division 1, which has all of the state agency amendments that talk about their authority and application and enforcement. 1.10 is OSHPD's application and enforcing agency information for OSHPDs 1 through 6 now. New OSHPD 6 was added in the 2022 intervening code cycle. And then we realized that these chemical dependency recovery hospitals are not always within an acute care hospital or an acute psych facility, and they are enforced by the local building department. These facilities are currently in existence and built throughout California and are not under HCAI's jurisdiction. This section was added to the building code in the intervening code cycle in response to Assembly Bill 2096. The statute permits chemical dependency recovery hospitals to be provided in a freestanding facility within a hospital building that only provides chemical dependency recovery services. And so what this is doing is essentially saying these are within the local building department jurisdiction. Now, if there was a chemical dependency recovery service provided in an OSHPD 1 or an OSHPD 2, then it would be within our authority. we're amending the model code section for temporary structures to state that OSHPD only allows one extension when cause is demonstrated. This is for temporary structures only. I'll hand this over to Samantha to talk about the CAN.
Thank you. So this CAN is meant to provide clarification of OSHPD's requirements for these types of facilities. The June update was a significant revision to this CAN. One of these revisions was reflected in the previous slide, that only one extension shall be granted by OSHPD, and that this request must be made and granted before the final approval expires. Other revisions in the document include allowing all disciplines and contractors to prepare the OSHPD submittal for temporary and interim structures per the requirements in the Administrative Code 7-115. The CAN also describes the specific circumstances in which temporary equipment can become interim equipment. This is permitted if the equipment meets the requirements for interim use, if its duration on site is linked to a construction project, and the construction documents are revised to indicate the change via an ACD. Lastly, a new section was added addressing the use of tents for patient care. Part of that is on this slide now, but it also provides an overview of the 3 jurisdictional approvals that are required for tents. These are the local building and fire departments who will review placement, anchorage, fire access, and conduct safety inspections. CDPH, who will approve the limited set of patient care processes allowed to occur in the tents, and OSHPD, who will review the project for potential impacts to permanent structures in OSHPD's jurisdiction created by a tent's placement and its utility use. Thank you, Mia.
Mm-hmm. So this was not an OSHPD change, but I want to bring it to your attention. This is a change that was authored by the Office of the State Fire Marshal, but we do work closely with them in making suggestions to some of the code changes. This is in Care Suites 407-443. And essentially what we've done here is adopted model code, or what the State Fire Marshal's done is adopted model code, which is why you see it in the upright language. And the model code included the allowance for using horizontal exits, and so we wanted to make that clear that that is allowed. One thing I forgot to mention when I started showing these slides with the code changes is the blue underlined text represents the change, and the gray stricken language represents what was being removed from the code. And when you see things in upright text, that's model code. And when you see things in italics, that's California code language. So I forgot to mention that earlier. All right, so we made a modification to the definition of invasive procedure. This is to assist design professionals to help them determine the classification of the imaging room or the procedure room necessary for procedures with varying risks. The defined term and the table, which is, it aligns with table 1224.4.11.4A, which is the exam treatment room classification table. This also aligns with the glossary information that's used in the FGI, the Facility Guidelines Institute for Hospitals Guidelines. And then HCAI and, not HCAI, HCAI and the California Department of Public Health continue to receive questions about the types of invasive procedures that are permitted in the various room types that are listed in the table. This amendment adds clarification that is provided in FGI in the explanatory note and assigns a risk percentage rather than stating a recognized risk. So meaning that it says, number 4 says a recognized risk was vague, and we're trying to better clarify that with saying a risk greater than 5% probability. These amendments were coordinated with Department of Public Health. And of course, they're responsible for licensing the facilities. We know this provides, this has some complexities to it. This is going to be ongoing. We've created a guide. It's called A10. I'll go to the next slide, and it provides some more guidance on imaging room classification.
This new A10 guide for imaging room classifications proposes the use of critical risk assessments, or CRAs, to assess and assign imaging room classifications. Even though there is no current code statute requiring a CRA, the guide strongly recommends its use to coordinate goals for the project and avoid late-stage licensing delays. These CRAs would be part of the patient safety risk assessment portion of the functional program that is already required to be submitted to OSHPD and to CDPH. The intent of the CRA is to engage the healthcare providers themselves as a critical part of a CRA team that would identify procedures and classes for each imaging room. To assist this process, the guide includes more detailed discussions of requirements for each class of imaging room. The guide further recommends pairing the CRA with one of 3 checklists that are provided as appendices. Each checklist corresponds to one of the imaging room classes, and each includes requirements from across the building code, including mechanical, electrical, and plumbing provisions. Each checklist also contains common imaging modalities used within that class. Thank you, Mia.
Mm-hmm. Okay, so we also amended table 1224.4.6.1. This is the station outlets for oxygen, vacuum, suction, and medical air systems. We also added footnote 9, 10, and 11. So the items 42 and 43, the sterile processing department cleans and sanitizes instruments and tools by using the healthcare facility for medical procedures. An instrument air source provides a clean air source so that the sterilized equipment does not become contaminated during drying operation. HCAI currently adopts NFPA 99 for healthcare facilities, which provides minimum requirements for the instrument air sources. NFPA 99 does not provide requirements for where instrument air outlets are required. The table includes the required medical gas outlet and inlet locations and is based on the FGI medical gas table, which is 2.1-3. The 2018 edition of the FGI guidelines for the construction of hospitals introduced the instrument air column to the medical gas table, which is why we've added it on the far right over there. And then the new footnotes obviously reflect the information needed to clarify for the central sterile soiled work area, clean work area, and then the processing. It's a pretty simple fix. I couldn't show this in blue. I apologize. There was confusion that emergency room treatment and comma triage rooms were all one, and we were putting the and in here to clarify those are 3 separate area designations. So we've also created an advisory guide for nurse calls, so I'll turn this over to Samantha.
This is the first design advisory guide issued for nurse call systems, and it uses PIN 60 as the basis for its requirements. The guide includes clarifications regarding the required placement of nurse call components per the California Electrical Code, testing procedures, sequencing for utilizing temporary nurse call systems while completing repairs and new installations, and the parameters that define repair or maintenance projects. These parameters can depend on the type of maintenance being done and its connection to the fire alarm system. The guide includes a checklist that may be used for testing and inspection of nurse call systems prior to being placed in service. Please note that PIN 60 has since been rescinded. Thank you, Mia.
Sure. You'll see this section pop up a few times. We amended this section to make patient storage requirements clear and consistent with the other sections that are in the other service areas like skilled nursing facilities, psych facilities, and chemical dependent recovery system services. They were all slightly different. Psych facilities are slightly different for a very specific reason. But we realized that all of these sections were worded a lot differently, but the key element to each is that each patient shall have their own storage for their personal belongings. Where we ran into some questions with design professionals and plan review is this grayed out part that says suitable for hanging full-length garments was vague, and what were the requirements for that? And then when we began to research HCAI and Title 22, we realized there really wasn't a requirement for hanging full-length garments or garments in general. It's just that the patient storage space is required. So we're repealing that requirement and just simply stating that each patient room shall include a separate wardrobe, locker, or closet for storing clothing and personal effects for each patient. Okay, so in the anesthesia recovery service space, we're making this section consistent with another section in PACU. This language was added during a previous code adoption cycle, and we realized that we missed this section to state that a minimum width of 6 feet of access circulation is required outside the curtain area. So this section, when we get into the pharmaceutical service space, we ended up going through and doing quite a bit of cleanup. But what we realized here is we needed a new section to define a hazardous drug storage room. And the United States Pharmacopoeia, which, USP, requires hazardous drugs to be stored in the hazardous buffer room, hazardous segregated compounding area, or a dedicated storage room that is under negative pressure and externally ventilated with 12 air changes. The hazardous drug storage room has been defined in the California Mechanical Code in Table 4A since the 2019 supplement. But we were silent here in the building code section 1224. The proposed or the amendment that you see here aligns with USP, and the storage arrangement is currently required under Title 16 of the Professional and Vocational Regulations and the Board of Pharmacy and Sterile Compounding Regulations. This is just a little cleanup language where we're adding shall be located in or adjacent to. This is for the hand washing stations in both the sterile compounding area and the segregated compounding areas. What we did was when we looked at the USP 797, that allows the sink to be located either inside or outside the anteroom. And the term adjacent is an OSHPD defined term in section 1224.3, and that means located next to but not necessarily connected to the identified area or room. A little bit more cleanup when we were reviewing. When you look at the pharmaceutical service space on paper, I felt like there was some wayfinding that needed to be done in the various sections. So we were really clear about being consistent with defined terms such as the hazardous drug area and using this HD, putting hazardous buffer room, hazardous in front of buffer room. And then the amendment for pass-throughs is we're removing the prohibition of a pass-through between the hazardous drug buffer room and any unclassified area, and we're adding a restriction for the refrigerator pass-through. And then, of course, adding the word hazardous in front of segregated compounding area. Okay, I'll turn this over to Samantha to talk a little bit about the updates to the design guide.
The Sterile Pharmacy Compounding Guide compiles the varied and detailed requirements for compounding pharmacies that exist across several titles of the California Code of Regulations. Regulatory citations from other codes and titles are included in the guide user's reference, but the verbatim excerpts from regulations other than Title 24 have been removed. A recent revision reorganized and clarified architectural and mechanical requirements, with a new portion of the guide specifically addressing sterile compounding areas. Mechanical code requirements have been added and or updated within the checklists and the graphics in the appendices of the guide. Thank you, Mia.
Sure. Oftentimes the code modifications that we propose have to do with something that will happen in the field after a project is designed, it's been approved, and it's out there being constructed, and then it's inspected by either CDPH, or in this case, it was CDPH for the dietary folks. And so what we learned is that the state law Division 104, also known as the California Retail Food Code, requires that these pot washing facilities must have 3 compartment sinks rather than just multi. So that's the reason for this code change, is we don't want someone to install, let's say, a 2 or less compartment sink and then it not pass inspection. We're replacing the term immediately adjacent with immediately accessible in a couple of these areas. Just a reminder, HCAI has a location terminology, which I'll show you in a minute, in section 1224.3, and it includes adjacent, directly accessible, immediately accessible, in, and readily accessible. This is the correct term used. This is the correct term that's needed for these 2 sections. We'll just pop over to that. So this is just a definition reminder for folks. And the blue here is not a new change. This was already in the code, but it just is clarifying immediately accessible for you. So this amendment clarifies that the pediatric patient area and the adolescent patient area are separate from each other, and they're also separate from the adult nursing unit. The proposed amendment further clarifies that the common areas may be shared and used by pediatric and adolescent patients at different times. This amendment aligns with Title 22, which is again part of CDPH's licensing requirements. There's a related section to this in the psych facilities in 1228.30. So we're still in 1224, but we're talking about the psych nursing area. This is another one where we were looking at some other sections in the psych nursing unit, and as we were reading the general provisions, I felt like the focus really needed to be on the psych nursing area that provides acute medical care, making sure we're staying within 1224, versus a non-medical psych nursing unit that we point over to 1228. So that's just cleanup language here. It's not really a new regulation, but it's just sort of better clarifying. And you'll see when we have a few more slides later, we do make similar changes in 1228 in the general provisions. Another change that we found necessary in the psychiatric nursing unit is the activity space. Currently in 1228, we have information about activity spaces, but in 1224, it was pretty general. And so we're adding the activity space shall be provided in compliance with 1228, except as modified below. And so there's some information about indoor activity rooms that are necessary, and then outdoor activity spaces. And those need to be dedicated for use by psychiatric nursing units. So now we're in the point 33, the emergency service areas. And we already had a section for behavioral health observation area. What we're cleaning up here is that the oftentimes in these areas, beds and gurneys are not necessarily used for the care of patients. Recliners are used, so we added the word recliner to provide flexibility for how they can be laid out. And then we just cleaned up the clearances that are necessary around those recliners. And again, that is based on information in FGI and other standards we take a look at. So there's some changes to the fast track area in emergency services. And as we were reading these different subsections, it got a little confusing as to the difference between a fast track room, which would be a walled space, or a fast track area, which could be more of an open bay layout. So we tried to clean up that language here, and it just says, you know, the room shall have a minimum of 100 square feet, but in an open bay fast track area, each station shall have a minimum of 80 square feet. And then we get into each patient care station shall include the documentation area, and then each fast track room shall include a hand washing station, but in a fast track open bay area, which would be multiple open areas, only one hand washing station is necessary for every 4 beds. I'm just trying to break that out so it's very clear. So rehab area. Just looking at my notes here, refreshing my memory. Okay, this clarifies that the physical therapy service, occupational service, and speech pathology service are required services for rehab centers. And the space for these services shall meet the requirements indicated in the specific code sections. This was also something that we needed to align with in Title 22. So what we learned is if you have inpatient rehabilitation therapy, you also need to provide the outpatient rehabilitation services. And at minimum, an exam and treatment room shall be adjacent or directly accessible to an office. And then for outpatient rehab, you need a patient waiting room with access to a phone or drinking fountain. And of course, the restroom facilities shall be adjacent to the rehab outpatient. And then what we added here is chemical dependency recovery, and they use the word hospital because that's what's used in the law, but it's a service. It can be part of general acute care hospital. And so this is a supplemental service, so we're adding this information in the supplemental area of 1224. Okay, shifting over to skilled nursing facilities, we're close to the end of the presentation. There's not a lot more on 1225, 26, and 28. So I'm going to pause. I have been, while Samantha's been talking, I have been looking at some of the questions, and some of them are getting really technical and they may be very difficult for me to answer today. So I'm thinking, really great questions, by the way. I'm thinking we may want to go offline with some of these. So that we can spend time and maybe ask a couple of our other team members answers to some of these questions. So I apologize, there's some of these questions I'm just not going to be able to answer today. We may have mentioned this, but we're going to download the table and then we'll answer them. And then, of course, if there are specific project-related questions, we'll probably defer you to the regional manager for those specific questions. And then you can always email us at our regs unit email, which will show at the end of the slideshow as well. So I'm going to keep rolling here real quick with, so skilled nursing facility, patient storage. This slide's been up for a minute or so. Again, this is consistent with with what we put in 1224. Same reason, just getting rid of the hanging, well, this doesn't have the hanging closet, but separate wardrobe, locker, or closet for each patient. So this has also come up during licensing, and we put this provision in here to align with Title 22. So special treatment program, STPs, we found out that the facility needs to have a minimum of 30 beds to meet the requirements of Title 22. That said, after we, just so you all know, right now the sentence says the skilled nursing facility shall have a minimum of 30 beds, but we think looking back at the law, it really should say the special treatment program shall have a minimum of 30 beds. And so we're going to probably make that change in a future code cycle, but the concept is the same. So here's a little cleanup language. In prior code cycles, we've changed medicine to medication. So this is just some cleanup in this general provisions for clinics. Surgical clinics, we had a question that can procedure rooms be, are procedure rooms allowed in a surgical clinic? And yes, they are. The code was silent on that. So we're just simply stating that they are optional. And when provided, they need to comply with the appropriate section 1224. So here we are in 1228, acute psychiatric hospital. Again, I talked about this earlier in 1224 under psych for a general hospital, acute psych hospital. And what we did is focus on an acute psychiatric hospital shall meet the requirements of 1228 for a non-medical unit. Based on the functional program. And then we get into, of course, the specific application shall respond to the patient injury, so on and so forth. Just cleaning up the language. So also in 1228, we have similar amendments to the patient storage. However, it's clear in patient storage that these types of shelves or folded garments shall be used instead of arrangements for hanging garments, and this is for anti-ligature. And then the pediatric and adolescent psych service space, again, we want to make sure we're clear that they are separated from each other and shall be separate from adult psychiatric service spaces. Again, this is in alignment with Title 22. But common areas, including activity areas, dining room, outdoor areas, and spaces for educational programs, they can be shared, but they need to be used at different times. And then just simply adding that a supplemental service in a site could be chemical dependency recovery. All right, I'll turn it back to Samantha.
This is Design Advisory Guide A4, Acute Psychiatric Hospitals, excuse me. This discusses requirements for acute psychiatric hospitals, psychiatric nursing units within general acute care hospitals, and special treatment programs with skilled nursing facilities. This guide discusses each kind of facility and the differences between them, and includes a flowchart to help the user identify and use the correct set of codes per facility type. It contains an example of the required functional program and the specific features required for psychiatric facilities. It also includes checklists for each type of facility. Earlier this year, a revision was issued that updated electrical language, especially regarding critical branch and alternative source of power requirements. Thank you, Mia.
Mhm. So then, as we mentioned before, new section 1229 was added to the code a couple code cycles ago. Again, we're editing patient storage room, and then cleaning up some language that is in 1229.31 for other chemical dependency services. Just rewording that slightly. There was a sentence that wasn't quite a complete sentence. Okay, so that concludes the presentation. I was trying to go through and look at some of these questions. Just bear with me real quick. There's one that says, is a non-medical psych nursing unit designated OSHPD 5? That's correct. That's correct. And since it is non-medical, can it be housed in a 1R? That is correct as well. Yes. Really under patient activity spaces be shared resources or dedicated to each nursing space. I'd have to look at that. Yeah. New construction projects adopting. I don't think there's, for new construction project, is HCAI adopting? No, we don't adopt ICC's ANSI 117 for accessibility. We still defer to what is in Chapter 11B, which is amended by the Division of the State Architect. So there would not be a 67-inch turning radius. Yeah, some of these are really specific, so I don't want to. Let's see here. Okay, I think we're going to download these and have to answer them because they're getting into the weeds on some of the admin code changes. And I would want our electronic, our person that's more familiar with the electronic process to help answer some of these. I think at this point, unless anyone else has anything to chime in on, Samantha, I don't know if you saw anything that you can answer. Does the checklist per design advisory guide will be required for projects submitted prior to January 1st? I don't know that the checklist is a requirement. I think that's just part of the guide.
Mia, I do see
Yes.
a question about the A10 guide.
Sure, go ahead.
Joseph Warner, is a template or guide available for the CRA? The A10 guide references the 2026 FGI, which is not even available yet. So we did reach out to FGI to see if they would allow us to use their template for the CRA, and we were politely declined. And so given that the breadth of procedures that can and imaging that can be done in imaging rooms and the number of different health systems in the state, currently we just determined that it would be very difficult for OSHPD to maintain a template or a specific guide for a CRA. And so we are asking project teams to look towards the 2026 FGI so that they can use their template.
Okay, thank you. And I saw one more come in. Does the temporary installation apply to equipment? I can kind of answer that. I think actually the CAN that Samantha spoke to is pretty clear on that. So if it's temporary because of construction, yes, it is temporary. It does apply. So what's happened in the past is someone will bring in temporary equipment for, let's say, just an emergency or during construction. Once that construction project is complete, that temporary equipment is supposed to be removed and rely on whatever the new construction would rely on. So, you know, there again, an extension can be granted, but it would depend on the circumstances of the project. Drafting a code section specific to CSU for behavioral health. Do you know when it is coming out? We also heard it will require 3 feet on either side of the recliner. Yeah, so that's a future code cycle. So I'm not going to speak to a draft provision that's out there right now. But yes, we are working on. It's not CSU, but it is for outpatient behavioral health. We are working on a code change for that. It was presented at our September 10th HBSB Codes and Processes Committee. That is also on our website. You can download the PowerPoint that was viewed and all the proposed code sections. Just on that note, that is draft right now. It's going through our executive office for review, and it'll be submitted to the Building Standards Commission December 1st, and then it goes through the formal public process. So there's still ability to chime in on those proposed code changes.
May I jump in with another one?
Absolutely.
Jay Kurian, I believe that if I don't answer both of your questions, we'll go back through and review and make sure that that everything gets answered. But your second goes and it points out that there's kind of a mismatch in the language for the categories or examples of NMAs. And that's something that we just caught ourselves within the last week, where it is a little bit conflicting language. And so there will be an upcoming revision to this CAN to clarify that these are just examples and you don't have to identify a particular section per NMA submittal.
Well, that looks like all of the, I know we didn't answer all the questions, but that looks like the one of the last questions that was added. So unless you see anything else, Samantha, I think that we're kind of at the end of the presentation. We're ending a little bit early today, but it's okay. We got through it. And should I turn this over to Simrit? Do you have something at the end of the presentation to add for us?
Yeah, thank you, Mia. This brings us to the end of our presentation. We hope you found this webinar to be helpful. Please remember, if you didn't download the PDF presentation, you may do so now by going to the materials section of the GoTo panel. Alternatively, the slide handout will be available on the HCAI website in approximately 1 week. Also, today's session has been recorded and will be made available on the HCAI website in approximately 2 weeks' time, along with the Q&A. If you have any questions about this presentation, please email the regs unit at hcai.ca.gov, which is also shown on the screen right now. And it's been a pleasure being with all of you today, and thank you for your time. Have a great day.